How can telerehabilitation improve motor control in patients residing in rural and remote areas? Please, Dr. Cikajlo, I hope this is correct.
I would like to thank first to the audience that come here. I would like to thank Dr. Tonin and the Institute Santa Ana to invite me here. And it's my pleasure to talk to the audience. I basically appreciate that there are so many people here wanted to hear what I'm trying to say. Well, I purposely didn't write all the titles and everything that you usually do at the name. My name is Imre Cikajlo. I come from Slovenia, and my background is robotic engineering, biomedical engineering. I spent a couple of decades working also in functional electrical stimulation, rehabilitation robotics, and as our main purpose of the University Rehabilitation Institute is hospital and treating patients, I also have some clinical experience. In spite, I'm not a clinician and I'm not a medical person. Slovenia is a small country, but it's in the middle of Europe. So basically, it has always been a bridge between East and the West, which was very convenient also for patients coming from the East, having contact with Western technology and vice versa. We have 220 beds treating about 12,000 patients per year, which is not really a bad number for a small country with 2 million population. What do we face all with one problem? Today's medical services basically has kind of a law, and insurance companies pay mainly for treatment that requires travel. So the physicians, the staff have to travel, and the patients have to travel to the care unit, and so on. And while the traveling of medical experts is essential, this basically makes a lot of problems with our future services that we call telerehabilitation services or telemedicine services. We want to access remote areas because this is the main reason to offer rehabilitation, but not only rehabilitation, but also medical services to the larger population. On the other hand, we want to use telemedicine and telerehabilitation as expertise and knowledge sharing. But in contrary of that, we actually got digital health with a lot of data that we can't handle usually, and we expect, including me, including myself, that the physicians, that the healthcare personnel will analyze all these data. This is nearly impossible because they don't have time to do that, and they can't really distinguish which data are important and which data are not important, and that's why they rely only on clinical data. In spite, there's a lot of data that are provided in the services of tomorrow. No matter whether we have family care, remote diagnostics, or we have telesurgery. Oh, this works. Can you see this? No, you can't. Only on dark area. Okay. Its laser is basically functioning only on the ceiling, yeah. So even if we have remote care or any other services that are use data, and these data needs to be somehow fused to have reliable information. So telediagnostics is one of the things that usually comes with telerehabilitation as well. And it comes also with telesurgery. And these data actually require ICT services and also data from digital health. However, nowadays, most of you have already heard of data assessment, artificial intelligence, neural networks that basically fuse data. So what does it mean? It means that someone who is not really capable of reading all this data could get a valuable information to make decision. So this is not a tool that will make decision instead of the healthcare personnel, but it will help the healthcare personnel to make decisions to change the therapy, to change the protocol, which is one of the most important thing of services of tomorrow, that we can change the protocol online without seeing the patients and so on. So we can change the difficulty level and so on. In 99% of the treatment, neurorehabilitation starts in the hospital in acute phase. Then in a subacute phase, patients are usually discharged, and then we face with no therapy, usually only blood pressure control or video consulting. So we have options that we have remote treatment, or we would have, let's say, home therapy, but we all want to have a continuation of rehabilitation at home to have a longer period so that we don't really come to the chronic stage very early. We will come to the chronic stage anyway, but we need to prolong this period. And in this period, we need telediagnostics so that we can change the treatment protocol, the difficulty level of treatment protocol, personalize the treatment protocol, and of course, schedule the outpatient visit. So less outpatient visits we can save some money for the hospital and for the insurance companies. We would imagine that we would have in the future remote centers, homes, and with broadband internet connected to the specialized centers where the experts could evaluate this data, could change protocols, and so on. And it's not necessarily be our own hospitals. For example, this data could be validated in Italy, in France, in Sweden, or even in India, when some people sleep in Europe. And then we could change in the morning the program. Of course, some of the things are possible only if we do have a smart home on the other side, and we have very well equipped home care units, or even smart homes, which is, I think, in the far future, it is not really accessible to the rural population. But we all agree that Teleneurorehabilitation after stroke requires 4 important things. That is intensive therapy with a lot of repetitions. We need gradual increase of task complexity so that it's not boring. And we need to focus attention, so the patients need to be focused. If they're not focused, if they're not doing what we want, they're just having fun or doing it just because they have to, it won't be effective. And of course, we need to make optimal schedule of learning tasks. Why do we need to do that? To save us also some fundings. Well, in previous world, we had manual physiotherapy that required several physiotherapists to handle difficult, heavy persons. We had no repeatability. Then we used the balance trainer. The balance trainers allowed us a lot of things, especially repeatability, without so many physiotherapists. Adding motivation and targeted games was in 2005, was very easy to do it. However, this was like to do the task, which was very important, not only from the focus perspective, but also that they will, they get a reward, that they finish some task. In virtual reality, we have plenty of options. We can change the goals. We can add other objects that are different colors. We can add difficulty. We can decrease difficulty levels. We can simplify the environment so that it's not distracting and not, annoying for some typical diseases or typical neurological disorders and so on. So it just depends on the treatment. And of course, at the beginning, we need a physiotherapist or the care person to help the patient to do any kind of task. So here we start. And later on, we can start with telerehabilitation online, so one-to-one, like here. So the patient is using the balance trainer. This device provides him safety, so he can basically not fall. And lean, and changing the posture, he's controlling the virtual reality game. On the other side of the wire, we would have live the physiotherapist looking at the browser and using Skype to communicate with the patient. So now, after follow-up, also we get very encouraging results. All the clinical tests were basically positive with a bit of standard deviation, but we were happy because the sample size was a little bit small, so about 30 patients. So then later on, we did a study comparing virtual reality balance training in telerehabilitation and only balance training, and we find There were no statistical differences. What does it mean? It doesn't mean that one is better, but that Telerehabilitation with virtual reality balance training was as effective as the rehabilitation at a hospital, with less personnel, less days per week, and partly did at home. Unfortunately, there was some equipment that needed technical support, but at the end of the day, we got the same, almost same, a little bit better, but not statistically different clinical results, which was what we wanted to. Later on, we added also haptic floor. Haptic floor basically provides postural responses, so the patients could train also postural responses. And I'm not sure if the video will work. It will. So the task was pretty much the same. We used balance board only for data assessment here, so it wasn't used for any other purposes, because the video was done at the study. So the patient could basically feel the environment and also train postural responses. So in upper extremities, we developed a so-called universal haptic drive, which allowed us to control the arm or the wrist and do tasks in the virtual environment. However, this device was too complicated. That's why we have Arm Assist 2, which was developed by Technalia on basis of this robot. And it is still used only in care units, but it has an interface that is connected to the database, so the data is available to the physicians. It's much easier to handle with Parkinson's disease, is it? Well, at least persons with Parkinson's disease do not need a robot, because installing a robot at home is nowadays still a very big problem, and it's a very big social issue. Don't even mention that it's a very big financial problem. But in Parkinson's disease, we wanted to have also numerous repetition and targeted tasks to achieve better activities of daily life living without changing the medication plan. Usually the Parkinson patients increase the amount of medications, and this is not what we wanted. We wanted to keep the medication on the same level or even lower level and have the same activity. We developed tasks similar to box and boxes in the virtual world, try that in 2D, so using only a laptop, which is a very cheap option, or using in 3D with the Oculus Rift. And we got encouraging results. We basically got improvement of box and boxes, UPDRS tests in both groups, and the 3D group was even better in performance. However, they had larger tremor indicator, which means we measured the frequency of tremor when handling each boxes. Well, when we go into the motivation inventory questionnaire, we realized that people using the 3D equipment had a large amount of stress, so the pressure, tension, and they were still effective, while the other group, the LCD group, has much less pressure. And if we see this graph, the lower one, we would see that if the pressure decreases, then also the tremor decreases. So this was somehow correlated. I wouldn't go into details because this was not the point what I wanted to say. Then we went to picking apples using Microsoft Kinect, and we also came to the conclusion that some of the tests, like box and blocks test, and also some of the Jepson's tests, were rather positive, even statistically significantly better after 4 weeks. That's why we put the whole thing into the Teleneurorehabilitation concept, connected to the server, have a front end at home with very simplified interface, with minimal equipment, and we added medication management. So that means we had information in the database how and which medication they took. And this rather complicated on the left lower side was used for physician to schedule which task, which difficulty level of the task they will provide. Difficulty task was basically how many apples fall, the speed of falling of apples of the tree, and the speed of boxes and so on. So this is this was. And we put that into the European Framework Project PD Manager. This should work because it's the Windows media file. So we see Parkinson's disease patient efficiently performing the task. So here is an example in the clinic when the occupational therapist is testing on a large screen. And there is a Parkinson's disease patient doing it with the Oculus Rift. What is the advantage of using virtual reality boxes? We can change the bouncing ability, the material of the boxes. So it's not a competitive to the real world, but it's an environment where you can change the parameters as you want. If you make the boxes unbounceable, it will be very easy to do the task. If you do the box very light and bounceable, it is very difficult to catch a virtual box. And that's what makes very difficult the task in itself. And it is also challenging. And then we came to the topic, which is very important, as stated in the title, rural vs. urban concept. In urban concept, we have very fast internet, so we can have online data processing. We can even have it remotely in the webs, so that the patient does not need any equipment at all, just a sensor and a wireless and a wireless unit or the plug-in. However, this is not possible in the rural environment. Even in PD Manager, we had irregular broadband connection interrupts. So we need to change entirely our concept and saving data first locally and then transferring to the server. But both concepts have a lot of things in common. First of all, we all want to have home therapy, so we want to have a continuous home therapy after discharge from the hospital. We want to have supervision and consulting remotely, which is an issue that was already emphasized in previous lectures. So it's cost a lot. The physician and the staff doesn't have really the whole day time to talk to 1,000 patients. How are you going to do that? And of course, who is going to pay that when the remote service is not recognized as a medical service? So we still want to have remote monitoring and data analysis. For that purposes, we have now ICT tools that could provide us a bit of help. And what is even more important is that we can do even now, that is online scheduled outpatient visits. So we just don't order the patient every 3 weeks, but we do it when we need it. So if there was no significant or no improvement, we have to see the patient. We have to see what's going on. If there was significant improvement in 2 weeks, we could change the difficulty level of the program, and we can leave the patient for another 2 weeks, and then we can have the outpatient visit. So it's not scheduled, but it's dynamically scheduled, which is one of the most important things, especially for the rural areas. About 4 years, it was published the economic concept of telerehabilitation that says that the distance above 30 kilometers is definitely the one that should need telerehabilitation services. And when the distance is even over 50 kilometers, that would save about 1/3 of the money. And this result was statistically significant. So let me conclude. So we all agree that we need a program that will enable prolongation of the rehabilitation period so that the patients will not stop with the rehabilitation immediately after discharge of the hospital, because most of them who are not residing in urban areas are not really very keen to travel back to the home care centers. And this will provide less pressure on the rehabilitation centers and hospitals, so the local care units would be able to do it, or even later at home when they have a little bit more equipped home. And the patient will have more independence, and they will return to their relatives if they want. Some of them residing in elderly homes, they will also have an option to do the rehabilitation there with teleconsulting, Teleneurorehabilitation programs, and so on. And of course, there is always a publication. I think every 5 years you can review about 200 papers that provide an economic view of the telerehabilitation services as well. So here at the moment I need to thank also our sponsors for financial support, the Slovenian Research Agency, European Regional Agency, and of course the Horizon 2020 European program. And of course I would like to thank the audience, and I'm open for question and discussion. Thank you very much.
Thanks to Dr. Cikajlo for your outstanding presentation. You highlight the role of artificial intelligence. From my point of view, this is the future for many scientific fields. For this reason, I would like to ask you your opinion about how artificial intelligence may be used in telerehabilitation. In which field, in which application?
Well, as I already mentioned in the lecture, we will have enormous amount of data available. So clinicians would not be able to distinguish which data are important, which are not. And so here, the artificial intelligence will fuse the data and provide a valuable information. So it will not make decision. In one of the projects, we tried also decision-making, and we realized that decision-making was not better than the physician's one. And also the physicians made statistical mistakes in 56%. So we are not that accurate as we think we are, isn't it? But at least, how you say, at the moment, we cannot leave the decision-making to the computer programs, definitely. But it could be a very good tool.
Other questions? Three questions.
Thank you. That was a very, very interesting presentation. I would just like to share our experience. I work as an occupational therapist in a private rehab center in the UK. We use a lot of virtual reality technologies, and we have done some studies while patients are in chronic stages, and also now we're doing a study in community-based settings for our patients. So what interesting factor is, yes, I totally agree, it's just a tool that gives clinicians, it's a decision-making tool, because what we are focusing on is the quality of the movement rather than the repetitions that the data gives us. So I totally agree with that, and thank you so much for it.
Thank you very much. That is what I forgot to emphasize, that the quality of movement is also important, because the end of rehabilitation are usually evaluated with clinical tests, and clinical tests do not basically provide the quality and all the data analysis, the progress of data.
And we've gone a step further. We have translated these movements into function and then monitored the functional implications through FimFam. So technology is just most essential part of our treatment plan now. Thank you.
Thank you very much.
Thank you very much for your presentation. This is a very practical question. I noted with the Parkinson's patients, they wore the headset goggles. Could you just let us know how people responded in using the goggles? I mean, there is the tendency for some sickness, that cyber sickness, I think they call it, where people find that difficult being in that environment with the goggles on. And I'm just wondering what your experience was with people using the goggles.
In this case, in 10 cubes, they were basically good experience.
Okay.
However, when you have environment moving very fast, yes, indeed, that's very annoying. Not only for patients, also for us. It's fun, but if you realize that there is a nice vertigo that you experience when you rotate the environment very quickly. So that is a problem we need to take in consideration when we develop 3D world. On the other hand, they were very nicely focused only on the task, because they had nothing else to see and nothing else to hear, because they also had headphones. So they were more focused. However, as you see in the IMIC questionnaire, they were more on pressure, they were more pretentious. So they felt like they have to do it very good. So they have to perform very well. So, but that has probably nothing to do with Oculus Rift.
Okay, thank you.
Last question.
Yes, it was more a technical question. Are you using the leap motion and Kinect data as a base for the artificial intelligence? Or how are you doing it from the house of the patient?
Yes, indeed. You guys, you're right. We are doing motion data from leap motion and from Kinect as well. At this stage, the data from Kinect was only used for analysis. But from leap motion, yes, indeed, we use data for each finger analysis, from palm analysis, and so on. It is not a really reliable data, but it's for this kind of application, it's very good. I mean, 40 hertz is nice.
Thank you.
Okay. Oh, yes, we've got another question just there.
Yeah, it's around the same. Like leap motion and kinetic is now not more available in the commercials. Like to buy it, and now if you have other options, like to think and to make new studies. You know what I mean?
Well, that was only, how we say, a prototype, a concept. When you move to the product, my experience or our experience with going from the prototype till the product, the company will totally make different things. So the end product will be different. They will find cheaper versions. If there are no cheaper versions, they will do it their own way. So for the research purposes, yes, we will do similar devices. We will look for the market, and there are always similar devices. I think there is already, Kinect has been replaced by another 3D camera, which I don't have on top of my head the name of the product, but it already exists. Leap Motion still exists. You can buy it in the US. I don't think it's available in Europe, or do they have they used to have a branch in UK.